and Dr. Bindu, and the youngest student, Dr. Purushottam sir. So once again, I welcome all of you. Thank you.
Balendra. Sir. So good evening, all respected teachers and my friends and my students. Our Amdeshan sir, Mohandas sir, Purushottam sir, our Darli madam, Sushma madam, Srinivasan sir, Virendra Umar sir, Dr. Bindu, Dr. Thomas, and all my PG students. So as president of IAP Kottayam, I'm very happy to be part of this PG club. Hopefully I will be regular in all the meetings from this week onwards. Actually, when I did my PG 3 decades ago, the most advantage of this PG club is we won't be able to meet all the teachers throughout the state and externals. But now the PGs have the advantage of meeting all the externals as well as other teachers throughout the state. It's the biggest advantage. And hopefully this PG club program will be very useful to all the PGs in the state and across the country. I wish this program all the best. Thank you.
Shimmi, President IAP Kerala. Hello.
Shimmi.
Okay.
IAP Kerala ആരാണ്?
IAP Kerala.
രഞ്ജിത്തിന്റെ.
അവന് ഷിമി ഇല്ലായിരിക്കും. ഷിമി ഇല്ല.
That case, ഷിമി sir out ആയിരുന്നു. Hello. കുഴപ്പമില്ല സാറേ, കുഴപ്പമില്ല, നമ്മള് കണ്ടിന്യൂ ചെയ്തോളാം. ഓക്കെ, ശരി ശരി. In that case, I would like to invite Dr. Thomas Varghese, who is the Assistant Professor of Pediatrics, ICH Kottayam, and also the Zonal Coordinator, to introduce the lead discussant and also the case.
Good evening, all. I would like to invite our own Virendra Umar sir, currently the head of the department and professor pediatrics, Travancore Medicity, Kollam. He was our former professor from Kottayam Medical College, Department of Pediatrics, and sir is a very sought out postgraduate teacher, and I welcome you, sir. And the case will be presented by Dr. Divya. She is the second year junior resident of Department of Pediatrics, ICH. And the case will be a 6-month-old child who came to a pediatric ICU as a case of failure to thrive. And we can start the session.
Okay, shall we start?
Sir, okay.
Okay. Good evening, everybody. First, let me thank all the IAP office bearers, state office bearers, and Kottayam district office bearers to give me the opportunity to chair this session. So we will start the case. Divya, you can share the screen and we will start.
Requesting all others to mute, otherwise some noises will come in between.
Decision had to be taken. Order has been passed.
Then shall I start?
Yes, start.
Good
You
evening.
can share your screen also. You can start first sharing your screen.
Good evening to all, respected teachers and dear friends. I'm presenting the case of a 5-month-old boy born on 17th of September 2023 from Rani, Pathanamthitta. Informant is mother. Information is reliable. Baby was admitted on 25th of February 2024 and examined on 27th of February 2024. Presented with complaints of poor weight gain, 3 months duration, vomiting of 3 months duration, cough of 2 weeks, and fever of 1 day duration. History of present illness. 5-month-old boy presented with complaints of multiple episodes of vomiting since 3 months of age, about 6 to 8 episodes daily, both soon after the feeds or within 30 minutes of feed, copious in amount, containing milk acid, and is non-bilious and not blood-stained. Baby was active throughout these months and was fed on demand. Parents also complained of inadequate weight gain noticed since 3 months of age. He was born with a weight of 1.9 kilogram, which increased to 2.6 kg by the end of 2 months. Baby was initially fed with express breast milk and formula feeds and correct dilution via bottle. Feed volume was about 40 to 50 ml given too early. After 2 months of age, he was mostly taken care of by a daycare attendant and was solely on formula feeds as his mother was working. And they used to give about 50 to 60 ml formula in the 3rd month. By 4 months, feeds were hiked to 60 to 70 ml and now gives about 70 to 80 ml per feed. But in case the baby vomits excessively, the amount is reduced to 40 to 50 ml in the subsequent feeds. There are about 9 to 10 feeds per day, and since past 3 months, there is no consistent weight gain. Currently, the baby
Screen is not visible.
Sir, screen is visible, sir.
It is visible.
Screen is visible.
Yeah,
It is visible, sir.
visible, sir.
Screen is visible.
That's my
Screen
problem.
is visible.
There are about 9 to 10 feeds per day. Since past 3 months, there is no consistent weight gain. Currently, the baby weighs about 2.8 kilogram. For the above complaints, they consulted a hospital nearby 3 weeks before, was advised some oral medications, following which there was mild reduction in the frequency of vomiting to 4 to 5 episodes per day. 2 weeks before admission, baby developed cough, which was wet sounding and associated with nasal congestion, no diurnal variations, not associated with fast breathing, chest indrawing, or noisy breathing. There was history of upper respiratory tract infection in family members. Baby also had fever, which was a low grade that lasted for 1 day only and got relieved after paracetamol. Was consulted at a local hospital for the above complaints and referred for detailed evaluation. No history of loose stools, bulky, foul-smelling stools, or blood.
Before going to the negative history, we will discuss the problems of this child. So you said the main complaints are vomiting and inadequate weight gain. 2 complaints.
Yes, sir.
Complaints. Then cough and fever. Recent.
Yes, recent ones.
3 months onwards, vomiting and weight loss. That is the main complaint.
Yes, sir.
But you said the vomiting started 2 to 3 episodes initially also.
Yeah, in the newborn period itself, baby had vomiting, but it was.
From 3rd month. What is the difference between that 2 vomiting? Is it that regurgitation, not vomiting?
It is not regurgitation as per the history, sir.
You put the history of vomiting as from the 3rd month onwards.
Yes.
But in the presenting complaints, in the description, you mentioned vomiting early on, also 2 to 3 episodes of vomiting, isn't it? No.
I mentioned in the past histories.
Okay. Yes. So what are the, then we will go to the, is the past history. Okay, you continue with the negative history also. Also mention why the negative history is mentioned, or why this history, negative history is mentioned, that also you have to mention.
Okay,
No.
No history of loose stools, bulky, foul-smelling stools, or blood in stools suggestive of any malabsorption or allergies. No history of rashes suggestive of any viral exanthematous fever. No history of poor activity or poor feeding or abnormal odor of sweat or urine, and no history of jaundice. No history of seizures, which are all suggestive to rule out the possibility of metabolic diseases. no history of any abnormal posturing, no history of recurrent infection suggestive of immunodeficiency, no history of any feeding difficulties, no history of decreased urine output or frequency.
Yes, yes.
Past history. History of vomiting or feeds almost daily since newborn period, which were non-bilious and contains about 3 episodes per day, mostly after formula feeds. Baby was tolerating express breast milk well. And there was history of low-grade fever and excessive crying at 3 months of age. Consulted hospital, was said to have some ear infection, given oral antibiotics for 10 days. Symptoms subsided after 2 days. No history of poor feeding or poor activity. No previous hospital admissions.
Okay. So how will you analyze the history? We will ask to Arathi, another discussant, Arathi. How will you analyze the history? What are the possibilities from the history? One doubt, what is the dilution of feeds?
Dilution was appropriate, sir. 1 scoop in 30 ml of water.
Yes, yes. Is Arathi not there?
Yes, sir.
Any other
Sir,
login?
sir,
Then you nobody is there. Gopinath? No.
yes, sir.
Then Divya can analyze the history.
Sir, it's a 5-month-old baby presented with complaints of vomiting, more aggravated for the past 3 months with significant weight gain also. So the vomiting is
Baby.
with no significant weight gain.
Was it a term baby or a preterm baby?
It was a preterm baby, 35 weeks.
Okay.
Preterm
So
lead birth weight baby, 1.9 kilogram.
4 months. Corrected gestation.
Corrected gestation is 4 months. With multiple episodes of vomiting, which was non-bilious and copious in amount, and there was no history suggestive of any immunodeficiency or malabsorption syndromes. And
among the presenting complaints, which are the major symptoms of this baby? This 5-month-old baby started as a preterm baby.
Vomiting and poor weight gain.
Poor gain. Yes, yes. The first slide. Keep that first slide. First slide, keep. Yes. Poor weight gain 3 months, vomiting 3 months. Is cough and fever significant in the presenting complaints? Can we separate that?
We can separate that, sir.
Why?
Because it is more of an acute onset, only 2 weeks duration, and there was history of contact with AURI, and there were no danger signs in the baby.
Duration. Settled by 1 or 2 short period itself, it settled. So we can separate that, analyze the poor weight gain and vomiting. What is the anatomy, pathology of a vomiting? How will you analyze in this?
Compared to regurgitation, this was more copious in amount, and it was more frequent also, frequent enough to and more significant enough to cause a poor weight gain in the baby. So, despite adequate feeds.
Not that. What all anatomical areas can produce vomiting? What all pathologies in an anatomical area can produce vomiting?
It could be an upper esophageal cause.
Okay, esophageal.
Then it could be a gastroesophageal reflux disease due to decreased
esophagus. Inflammatory condition.
Gastric causes as such, maybe a gastric outlet obstruction, any stenotic lesions, any webs or atricias, or even it could be it is rarely due to an intestinal cause, because the vomiting episodes are soon after the feeds, and it is non-bilious also.
Okay. Okay. Then any extra intestinal causes for vomiting?
Yes, sir. It can be due to any metabolic errors, inborn errors of metabolism, then renal tubular defects, then milk protein allergies producing vomiting, then other malabsorptions in like cystic fibrosis.
Milk protein allergy is intestinal.
Intestinal.
Yes, extraintestinal is mainly through the chemotactic trigger zone, CT, ICT, all these inborn errors of metabolism, chemicals, high urea, high creatinine, ammonia, etc., acid, which stimulating that, and also autonomic vestibular stimulation, cardiac failure, which acts through the autonomic nervous system. So it can be intestinal or extraintestinal, which is possible in this child. Is it an inflammatory intestinal cause or a obstructive?
Possibly a reflux disease or an obstructive lesion, which is lately manifested.
What are the features of a reflective disease, gastroesophageal reflux disease? GERD.
Frequent episodes of vomiting soon after the feeds, and that too non-bilious. But baby will be more irritable and may refuse feed at times.
Yes, when there is esophagitis, the baby will be irritable. In the history, there is no irritability. Yes. Yes. Then poor weight gain.
Poor weight gain might be secondary to vomiting episodes, because there is even though they are feeding the baby appropriately, the calorie the calorie requirement is not met due secondary to vomiting.
Why you said that calorie requirement is not met?
Might not be because it was copious in amount and multiple times the baby is vomiting.
What are the causes for poor weight gain? Major causes, major.
Improper feeding practices.
Inadequate calorie intake.
Inadequate calorie intake or increased losses or increased requirement.
Calorie utilization. One of this. You said it is due to inadequate intake. Why?
Intake means a calorie is secondary to vomiting. The fed volume is not providing adequate, and the baby is not able to met the needs because of vomiting episodes.
Is the weight gain affected intrauterine period or extrauterine period in this baby?
Extrauterine period.
Why?
Because it was a 35-weeker with 1.9 kilogram birth weight.
And appropriate for a 35 week.
There
is no intrauterine growth restriction. Whatever weight affection is extrauterine. Okay. Extrauterine, what is the time of onset of weight affection in this baby? Is that history 3rd month onwards is correct or not?
There was actually similar episodes in the newborn since the newborn period itself, but the frequency increased after 3 months of age.
1 or 2 vomiting in the newborn period. You said it is not regurgitation, vomiting, active process. Regurgitation is a passive process. Vomiting is an active process. So it is vomiting, not regurgitation. 2 or 3. That increased in the 3rd month. That is why they are complaining of vomiting as a complaint from the 3rd month onwards. Is it?
Yes.
But is the weight affected in the neonatal period?
There was a significant amount of weight loss initially. Yes, at birth, sir. Due to some
birth weight and 11th day, what is the weight?
11th
day.
Yes, sir. There was a history of NICU admission on postnatal day 6. Then the weight was 1.6 kilogram. That was about 15% loss from the birth weight.
Okay.
when the baby was discharged from the neonatal ICU on postnatal day 11, weight was regained to 1.8 kilogram.
1.8 kg. What is the weight at 2 months? Then there is another weight at 2.6.
Yes, 2.6 kilogram. And thereafter, there is no consistent gain.
There is only 700 grams gain. From the 11th day to 2nd month, only 700 grams weight gain is there.
Yes, sir.
Is it appropriate?
No, it's not.
So weight is affected from early neonatal period itself. Before that, vomiting becomes significant.
Episodes.
It is affected. Is it correct?
Yes, sir. Yes.
Initially, only 2 to 3 episodes. Then 6 to 8 times vomiting is from 3rd month onwards. Before that, vomiting in the frequency of vomiting, before increasing frequency of vomiting, weight is affected.
Yes.
After the gain is only very few, very minimal. 2.6 current weight. What is the current weight of the baby?
2.8 kilogram.
2.8 gain. Only 200 grams in the remaining 2 to 3 months. It is only 200 grams. So weight is affected earlier, before the vomiting. So due to vomiting or something else?
Some other abnormality might be there.
Okay. Then what are the possibilities? If you combine this vomiting and weight, affection of the weight, poor weight gain and vomiting.
It could be due to some inborn errors of metabolism, or maybe in renal tubular defects, or secondary to hyperthyroidism. Some other diseases causing increased metabolic demand, like cardiac failure, but in this case, there is no history suggestive of that. Then cystic fibrosis is also excluded.
Cystic fibrosis, why excluded?
No history of recurrent respiratory tract infections. No history of
the time of recurrent infection in cystic fibrosis. Later.
Diarrhea. No history of diarrhea.
Diarrhea is not common in cystic fibrosis because there is mucosal, these secretions are thick. But malabsorption can occur. Diarrhea is not very common. Malabsorption stools due to pancreatic dysfunction, hepatic secretory dysfunction, cholestasis, exocrine pancreatic dysfunction. So there will be malabsorption. Diarrhea is not common in cystic fibrosis. Respiratory is later also. Then what about cow's milk? They are giving cow's milk?
No, sir. Only formula feed is being given.
Sorry, formula feed. There is formula is made from
bovine milk.
So is it that related cow's milk protein allergy?
There is a possibility, but no history of any. Again, only vomiting is there.
Yes.
Poor weight gain. Other symptoms like loose stools or blood in stools and other allergic manifestations.
Esophageal and gastric symptoms. No enteropathy features. But weight is affected. Without enteropathy, otherwise vomiting should be more severe. Then only weight will be affected. Here the initially vomiting was not that severe, but weight is affected from early period itself. Yes. Okay. So why you said that take that negative history? Okay. Why you said this negative history? What are the conditions you will rule out from this negative history?
Malabsorption syndromes.
Yes. Rashes.
Rashes was actually it could be part of an inborn error of metabolism, or maybe because the child was having fever.
Which inborn error of metabolism presenting in this period produces rashes?
Multiple biotinidase deficiency.
Okay. Yes. Biotinidase deficiency. Yes.
Then abnormal posturing and seizures. I mean, abnormal posturing was for any reflex disease, as part of Sandifer syndrome. In severe GERD, it can be seen.
Yes. Poor
Then-
activity, poor feeding.
Poor feeding, poor activity, or for sepsis and IEM. But this is a longer course, so sepsis is unlikely.
Yes.
Then recurrent infections, immunodeficiencies, and decrease urine output to quantifying the urine output to assess the dehydration status.
Yes. Decrease the urine output or increase the frequency for dehydration. Or any other particular conditions which affects the weight and also vomiting. Any other pages? Arathi, Ashwati, Gopinath? Free to answer.
Renal tubular acidosis.
Urine frequency changes. That is polyuria, oliguria. With weight affection.
Increases polyuria.
Okay. Then what all conditions affecting the weight were this negative history?
Inborn errors of metabolism can affect.
No. This urine output frequency. Urine out frequency and weight. Can it be adrenal disorders, congenital renal tubular acidosis, polyuria, diabetes, diabetes
Insipidus.
all can affect the urine output. Yes. Yes. Continue.
Antenatal history. Baby was born as a third child of non-consanguineous marriage. Mother got conceived at the age of 33 years. Had regular antenatal checkups. In the first trimester, no history of any hyperemesis, hypothyroidism, fever with rash, urinary tract infections, exposure to radiation, drug intake or spotting per vagina. Dating scan was normal. Folic acid taken after confirmation of pregnancy. In the second trimester, quickening was felt at 5th month. No history of gestational diabetes, gestational hypertension, thyroid illness, and bleeding per vagina. Anomaly scan was normal. In the third trimester, fetal movements were well appreciated. History of gestational hypertension was started on antihypertensives. No history of gestational diabetes, urinary tract infections, bleeding or leaking per vagina. Weight gain was adequate. Growth scan showed some abnormality in the Doppler, and at 35 weeks of gestation, mother got admitted in view of high blood pressure recording. Was found to have abnormal fetal heart rate and hence underwent an emergency cesarean section. Perinatal history. Born by emergency cesarean section, the birth weight of 1.9 kilogram. Baby cried soon after birth, was admitted in newborn ICU for preterm low birth weight care. Was started on formula feed soon after birth as mother was admitted in ICU and passed urine and meconium within the first 24 hours of life. Breastfeeds attempted on postnatal day 2. Baby was not latching well and hence continued formula feeds. On postnatal day 3, express breast milk was given via bottle. Baby was discharged on postnatal day 4 on express breast milk and formula feeds. The weight then was 1.8 kilogram. Following discharge, baby was not taking feeds well. Mother also noticed yellowish discoloration of baby's skin. Hence, baby was taken to hospital on postnatal day 6 and readmitted in newborn ICU. Admission weight was 1.6 kilogram. There was 15% loss. He was given phototherapy for 3 days, continued on formula feeds, discharged on postnatal day 11 with a weight of 1.8 kilogram. No history of seizures, hypoglycemia, poor activity during the newborn period. However, there were about 3 episodes of vomiting daily since then, non-bilious and mostly after giving formula feeds.
Yes.
Developmental history. Partial neck holding was attained at 4 months. Fine motor tries to reach for objects by 4 months. Social,
Corrected 4 months?
no, sir. Chronological age.
Chronological 4 months.
Social smile by 3 months. Language going by 3.5 months. Hearing, baby alerts to sound and follows light and fixes near objects.
So what is your comment about the developmental history?
Normal for age, sir.
Chronological age, the 4 month head control is not partial.
Chronological at 4 months. Now the baby is having partial neck head control.
Age is 5 months. Partial neck holding.
5
months. What are the CDC grading of head holding?
Grade 0 is no head control at all. Grade 1 is momentarily head control. Grade 2 is when the baby is kept on dorsal position, he is able to lift his head. And grade 3 is on placed. I mean, grade 3 is grade 2 is baby is able to lift his head when placed supine on the couch. And grade 3 is when placed on dorsal position, baby is able to lift off his head. Grade 4 is when placed on mother's lap.
Able to lift. Okay. The partial head control only by 4th month. Fine motor, okay, reaching the object. Social smile, 3 months. Chronological should attain by 2 months. Social smile is a milestone that is not much fluctuation. It should attain by 8 months, 8 weeks. That is 2 months. 3 months a little late. Okay. Fourth month head control should be complete, not partial. Yes.
Nutritional history. Baby was not breastfed as latch was poor, was on express breast milk and formula feeds 3 times daily till 2 months of age. Used to take about 40 to 50 ml too early in the initial 2 months. Had about 3 episodes of vomiting since newborn period, mostly after formula feeds, was copious and non-bilious. After 2 months of age, switched completely to formula feeds as mother was working, and baby was taken care of by a daycare attendant on most days. Feeds were given via bottle, and the dilution was appropriate. Feed volume was about 50 to 60 ml in the 3rd month and hiked to 60 to 70 ml by 4 months and now gives about 70 to 80 ml per feed. In case the baby vomits excessively, amount is reduced to 40 to 50 ml in the subsequent feeds. Time taken for each feed varies from 20 to 40 minutes and baby sleeps for about 1.5 hours after each feed, wakes up and cries demanding next feed. Total number of feeds is 9 to 10 per day. There were about 6 to 8 episodes of vomiting daily within 10 to 30 minutes of feed. Night feeds were present. Urine frequency is about 6 times per day and stool frequency once in every 3 to 4 days. And is yellow colored.
Yes. Urine frequency is normal, not increased. Okay. Yes.
Immunization history. Baby was... the immunization was taken from UAE and as per the schedule is immunized for age. No history of any adverse events following immunization.
The UAE schedule, that is why it is 2 months, 4 months. Okay.
Yes. This is the 3-generation pedigree of the family. Coming to family history, baby had an elder sibling who was a male child born via full-term normal vaginal delivery with a birth weight of 2.8 kilogram, cried soon after birth, no history of any NICU admissions. Parents noticed increased urine output in the baby and fast breathing in the newborn period itself. Consulted hospital, were reassured and was said to be normal. Baby was not breastfed as latch was poor. Hence was started on express breast milk and formula feeds, appropriate dilution via bottle. And after 2 months of age, only formula feeds was given as mother was working. Parents noted there was poor weight gain in baby, consulted many hospitals, was advised to increase the feed volume, but there was no improvement. No history of recurrent infections, vomiting or loose stools. No history of poor activity or feeding difficulties. Had a history of hospital admission twice during the first 6 months in view of dehydration. Was said to have low levels of potassium and elevated acid levels in blood. Both episodes were treated with IV fluids and some medications and was discharged after 2 days of IP care. At 6 months of age, baby had worsening of breathlessness, followed by decreased responsiveness. And he was admitted at hospital, was said to have some abnormality in the kidneys. Potassium levels were low. Baby went into sudden cardiac arrest and expired. He also has a second sibling, a female child born via full-term normal vaginal delivery, 2.7 kilogram, uneven full neonatal period, developmentally normal and thriving. Studies currently in LKG. No history of any recurrent abortions, renal diseases, congenital anomalies, or other infant deaths in family. No history of any allergies. Socioeconomic history. Father is 35-year-old, studied BCom, works as a salesman in UAE. Mother is 34-year-old, studied BSc nursing and working at UAE. Belongs to upper middle class family as per the modified Kuppusamy scale 2023. Lives in a rented apartment shared by 3 families. Common kitchen, sanitary latrine is present. Overcrowding present. No passive smoking or pets. Takes boiled water.
Okay, we will analyze the history. What are the summarize the history and what are the possibilities from the history?
A 5-month-old boy on formula feeds with multiple episodes of vomiting, even since a newborn period, the frequency being more increased since the past 3 months. And there is history of inadequate weight gain and a strong family history of elder sibling death due to some renal abnormalities.
Yes. With a recent lower respiratory infection, which is community acquired. A short acute short febrile illness, which is community acquired, not an unusual infection. Okay. So what are the possibilities? Possibilities order. So in the summary of the history, you can say 35-week normal intrauterine growth. Intrauterine growth restrictions and extrauterine growth affection, not intrauterine.
It's a case of failure, baby with failure to thrive, most probably pointing to some organic etiology. And
why it is failure to thrive? What is the definition of failure to thrive?
Weight for age less than 5th centile or weight for length less than 5th centile.
5th centile, 3rd centile or 5th centile. Okay.
Weight for length or BMI or weight for age.
And also weight catch down to major centiles.
Yes, 2 major centiles.
Okay. In what age?
Since a newborn period itself.
Failure to thrive. 6-year, 7-year-old child you can use. Can you use? Which age group you will use the term FTT? Age group.
Under 2 years of age, sir.
Up to 2 years. For a third world countries, we can use up to 5 years.
5 years.
Up to 2 years in the most of the definitions, it is 2 years. Yes. So it is a failure to significant. There is no weight 200 grams in the last 2-3 months. So it is failure to thrive. Yes. So development, you said it is it took the chronological age, isn't it?
Yes, sir.
Social smile chronological age 3 months.
Yes.
Isn't it?
Yes.
Corrected age, the confusion occurred. If you are using the corrected age for developmental assessment, you can use the corrected age. Corrected age 3, chronological age 3 months, corrected age is 2 months.
2 months.
Baby. So social smile is normal for that. The appearance of social smile is normal. Developmental history you can mention with the corrected age.
Yes, sir.
Not the chronological age. For which you use the chronological age. Developmental assessment, weight assessment, all corrected age. But for vaccination, immunization, you have to use the chronological age, even if it is a preterm baby. Okay. How long will you give the correction for prematurity? Up to what age?
50 weeks.
For weight, 2 years, 24 months. For length, height, height up to 40 months. At circumference, 1.5 years, 18 months. Till that you have to give correction. Okay. So development is, you can take it as normal. If you take the corrected gestation.
Corrected gestation.
It is normal. Yes. So what are the possibilities, your possibilities from the history? A failure to thrive.
Probably.
1, 2, 3, 4 possibilities.
Since there is a strong family history of elder sibling death, it could be an inborn error of metabolism or a renal tubular defect, because the elder sibling also had a very strong history.
What is your first possibility? Inborn error of metabolism. What are the points in favor and against in the history?
Favoring inborn error of metabolism is early onset of symptoms with vomiting, failure to thrive, and a strong family history. And the points against are no features of any encephalopathy, no features suggestive of poor feeding, then no other multi-organ dysfunction.
No encephalopathy till 5 months. And also, what about the feeding? Activity feeding, you said it is, baby is active. Appetite is good.
Yes.
Will that happen in inborn error of metabolism? IEM babies will be babies. So poor feeding, poor activity, lethargy. So only weight is affected and there is vomiting. So that is not a picture of IEM. Yes. There are many points against. Families, the infant death. Yes. Can it be genetic?
It can be an inherited disorder.
What are the points in favor and against?
Again, symptoms since a newborn period, and family history.
Usually, intrauterine growth restriction will be there. Major genetic syndrome or genetic defects affecting weight early, so early, will have an intrauterine growth restriction. That is not there. Birth weight is normal for the age. Can it be a cow's milk protein allergy? CMPA.
It's an absence of any enteral symptoms, only gastric symptoms is there.
Can it be pylori stenosis, hypertrophic pylori stenosis?
Usually presents in the 3rd week of life.
Yes, early presentation. Yes. Why it presents later? Hypertrophic pylori stenosis presents later. 3rd week. Can present later also. 2 months, 3 months time it can present. Mucosal edema. The mucosal edema, only after start feeding, the mucosal edema appears. Then only the obstruction will be critical or significant enough producing forward block. That is why the manifestation is a little later. It requires feed and mucosal edema. Yes. Early vomiting is less likely. And also, is it due to vomiting or is it due to some other else? The way before the vomiting becomes excessive, it is affected.
Weight was affected.
Is a point against pyloric stenosis or obstruction. Okay. Yes. Any other? Can it be any end organ dysfunctions?
No symptoms suggestive of any end organ dysfunction.
Yes. Which end organ can present as occult? Weight affection. It can occult, remain occult. Cardiac, there will be symptoms. CNS, there will be symptoms. GAT, there will be symptoms. There is no symptom of enteropathy, no symptom of encephalopathy, no symptom of cardiac failure or compensated heart failure. No symptoms are there. So any system involvement can remain occult.
Renal.
Can remain asymptomatic, but
renal.
Yes, renal. It can present as occult. Yes. So, what are the priority? 1, 2, 3.
One is renal tubular defects.
Tubular, how can we say? Why you said it is renal tubular?
Renal.
It can be renal malformations. Obstructive, pyloric, bilateral, vesico-ureteric reflex. Okay, go to the examination.
Sir, chat box, there is a question, sir.
Any other faculty, sir, please, Srinivasan, sir.
No, you are carrying on very well.
Any comments from anybody? Purushothaman, sir?
Sir, BK, sir? In the chat box, there is a question.
Discussion is an excellent discussion, Virendran.
Okay. We go to the symptoms because the time is 8:15.
Yeah, we had to finish by 9 o'clock today.
Okay.
We'll go ahead with the examination.
Okay, we will go to the examination.
General examination. Baby was alert, no pallor, cyanosis, icterus, clubbing or edema. Pulse rate was 134 per minute, regular rhythm, normal volume, peripheral pulses were palpable. Blood pressure was 86 by 56 millimeter of mercury, capillary refill time less than 3 seconds. Respiratory rate was 34 per minute, regular. Temperature was 98.6 degree Fahrenheit. Saturation was 100% in room air, and the GRBS was 100 milligram per deciliter.
Yes, continue.
Head to foot examination. Head appeared small. Hair, no hypopigmentation, no alopecia, thin and lusterless hair. Plagiocephaly was present. Anterior fontanelle was depressed, 2.5 to 2.2 centimeter. Eyes were sunken. Ears are normal. Oral cavity dry. No oral thrush. No cleft palate. BCG scar present. Loose skin folds in axilla. Chest and abdomen showed no deformity. Skin pinch goes slowly. Limbs and spine no deformity. Nail type of external genitalia. Bilateral testis palpable. Anthropometry. Weight for age observed.
General examination, head to foot examination, there is a dehydration. Some oral mucosa is dry.
Yes.
Eyes are dry, skin pinch goes slowly. There is some dehydration. So what are the conditions in a failure to thrive with non-diarrheal dehydration? Here there is no diarrhea. Non-diarrheal dehydration. No diarrhea in the history. No loose. There is dehydration. What are the conditions that can produce non-diarrheal?
General adrenal hyperplasia. CH.
Vomiting.
Neonatal adrenal hyperplasia, that is one. Yes. Then
Vomiting a male child. Failed to try. Very possibility.
Divya.
Increased, if there is increased urine output, there can be secondary causes.
Again, other endocrine causes. Adrenal, diabetes, and
insipidus.
Yes, renal tubular acidosis, tubular dysfunctions. Okay. Yes.
Weight for age observed was 2.8 kilogram, required 7 kg as per WHO chart. Inference less than -3 standard deviation. Length for age 51 centimeter, required 64, less than -3 standard deviation. Weight for length was at -2 standard deviation. Head circumference was 36 centimeter, required is 41.5, less than -3 standard deviation.
Is it microcephaly? Is it microcephaly?
Actually, it's in FPT, it can occur.
If you use the Dyne's formula, length is 51 centimeter. 51 divided by 2 plus 9.5 plus or minus 2.5, it will 36 will come within that, isn't it?
Yes.
It's not that much affected. Not that much affected. What is your interpretation about the anthropometry?
Severe underweight is there.
Yes, severe underweight and standing. But weight for length is
not at -2 standard deviation. No waste.
At -2. That is not that much affected.
Yes.
What is your interpretation? Is it nutritional?
No.
It is not nutritional. Weight is severely affected. Standing, severe underweight, but weight for length is not that. Nutritional weight for length will be significantly affected. Here the weight is 2.8 kg, 51 centimeter length means a normal term 40 weeks newborn baby. Length and weight, both are almost equal, proportionate, not that much affected. Okay, that also is point against nutritional cause. So dilution is correct, intake will be correct. Yes, continue.
This is the growth chart showing weight being plotted at 1 month of character gestation, about 2.6 kilogram, and at 4 months it is about 2.8 kilogram. So slightly below -3 standard deviation, and there is no significant gains.
Yes.
Length for age, weight for length.
Yes.
Examination of gastrointestinal system. Oral mucosa was dry. Per abdomen, no distension. Umbilicus normal. No visible scars. No visible veins. All quadrants moving equally with respiration. Soft and non-tender on palpation. No mass palpable. Liver just palpable 2 centimeter below the right costal margin. Span of 5 centimeter. Spleen not palpable. No free flow. Respiratory system. Rate was 34 per minute regular. Bilateral symmetrical chest movements. Work of breathing normal. Resonant note on percussion, bilateral air entry equal, bilateral normal vesicular breath sounds, and no added sounds. Nervous system, cry and tone was normal, allowed with moderate activity. Cranial nerve examination, bilateral pupils equally reactive to light. Ocular movements and fundus normal, no facial asymmetry. Baby was alert to sounds. Motor examination, posters lying supine with some flexion of elbows, hips, and knee. And tone was normal. Power 3+ and reflexes 2+ in all limbs, and spine was normal. Cardiovascular system, heart rate was 134 per minute, regular, normal volume, all peripheral pulses palpable, blood pressure recording 86 by 56 millimeter of mercury, no precordial bulge, no visible pulsations, apex beat at left fourth intercostal space, medial to midclavicular line, no palpable thrill, no parasternal heel, S1, S2 normal, no added sounds.
Yes.
Summary: 5-month-old baby boy, third born of non-consanguineous marriage with family history of sibling death at 6 months of age, history of NICU admission for neonatal hyperbilirubinemia and preterm low birth weight care, now admitted for recurrent vomiting and poor weight gain of 3 months duration, cough of 2 weeks and fever of 1 day duration. On examination, alert, malnourished, eyes sunken, skin pinch goes slowly, signs of dehydration present, loose skin folds and axilla, no organomegaly.
Yes, why you said no organomegaly? Liver 2 centimeter below the costal margin. Is it hepatomegaly?
Span was 5 centimeters.
5 centimeter span. You have not mentioned the consistency. Consistency also you have to mention. Even if the fan is span 5 centimeter, a firm liver is abnormal. So consistency also you have to mention. Okay. In the summary, starting weight also you can mention. It's a preterm baby with normal. Extrauterine growth is normal. Extrauterine growth is affected. So that also is a part of the summary. So the summary, after the summary, we have to make a provisional diagnosis from a few differential diagnoses. The order also of priority also we are making from the summary. So it's an extrauterine growth restriction. Then, okay, what are your possibilities? Failure to thrive is not a diagnosis. We have to put a diagnosis for the failure to thrive. Yes, organic cause. It is not a nutritional. No nutritional cause. Okay. The first possibility is in IAP. We have already discussed that IAM family history is there, but which IAM will present at this age with failure to thrive and vomiting only, without other symptoms, encephalopathy symptoms, no other symptoms, only this weight affection and vomiting, which inborn error of metabolism can present like that. What are the inborn errors of metabolism that can present with failure to thrive in this age, 5 months?
Fatty acid
to analyze the symptom, it is not a waxing and waning. It's a constant affection of the weight, and also vomiting also is almost constant, 6 to 8 times. Some decrease with an antiemetic given by the local doctor. Marginal decrease. 6 to 8 becomes 6, 5 to 6. It's a marginal reduction, but it is there. So which inborn error of metabolism can present like that?
Organic acid increase.
Small molecular toxic accumulation, small molecular metabolic defects, organic acidemias, urea cycle defects, but they will not be present like this. There will be other symptoms also should develop, like encephalopathy. Other symptoms also should be there in IM. Then only this is storage disorders, lipid storage disorders, glycan storage disorders that can affect the weight. But there also will be other manifestations, CNS manifestations, hepatosplenomegaly, visceromegaly, that is not there. Okay, then GERD. Oh, second is renal tubular acidosis, sorry, RTA. Differential diagnosis, maximum favorable history, we will take as the first.
Family history of...
Yes, family history is there.
Vomiting and failure to thrive.
Vomiting and failure to thrive. Renal can remain occult. Okay, but there is no polyuria. Usually, tubular dysfunctions will present as polyuria. Yes. Any history of oligomnios in the antenatal period?
No, sir.
Okay. Then GERD.
Baby had symptoms. Weight gain was more affected even before.
Symptoms you have to analyze clearly. Vomiting, just vomiting and weight affection. That is not the way you have to present. Vomiting is initially minimal vomiting, then it increased second, third month onwards. Before that, there is weight affection. So GERD will be proportionate to the vomiting. Weight affection weight will be affected according to the vomiting. But here the weight is affected disproportionate to the weight vomiting earlier also. In the early infancy, that's in the neonatal period itself, weight is affected. So GERD is less likely. And also GERD will produce an esophageal inflammation. So there will be other symptoms like
refusal to feed,
irritability. IM, again, another strong point against IM is feeding difficulty. There is no feeding difficulty. The child is active, not lethargic. Appetite is good, feeding well. That is not IM. Yes. Then milk protein.
In absence of enteral symptoms.
Favorable of renal tubular acidosis. Dehydration out of proportion to without diarrhea. Okay, that also is in favor of a renal disorder. Can remain occult. GERD is less likely, not a common. Milk protein allergy. What is the difference between milk protein allergy and milk protein intolerance?
Milk protein allergy will be associated with other symptoms of ectopic.
When there is an immune component, it is called allergy. When there is immune component. Irritability, milk protein intolerance need not be always immune. When there is an allergic immune mediation, that is called, that complication of milk protein is called milk protein allergy. Otherwise, it is a milk protein intolerance. And just vomiting without an immunological involvement is a milk protein intolerance. Okay. Milk protein allergy. Different segments of the intestine can be affected, but the predominant vomiting without any inflammatory features, irritability is not there, and no enteropathy features also. Only when there is small intestinal affection, then only weight will be affected. There is no loose stool. So the milk protein allergy also is, there are points against it. So in this order, how will you keep the 1, 2, 3, 4? Which will come first?
Renal tubular.
Yes, renal will come first. Renal disorder will come first. Second is milk protein allergy. Then third is IEM. Fourth is GERD. Okay. Normal development also a point against IEM. Immunized for it. Okay. We will go to the investigations.
Investigations on the day of admission, hemoglobin was 11, total count 10,640, the polymorphs of 40, lymphocytes of 54, monocytes 5 and eosinophils 1. PCV was 28.3, platelet count 4.7 lakh, RBC 3.46 million, sodium was 163 and potassium was 3.1. Calcium was 10 and RFT urea was elevated to 62 and creatinine was 0.5. CRP was negative 2.63. Thyroid TSH was 1.85, TT 4.7. And repeat investigations on 26 showed sodium still elevated 164 with 2.9 of potassium. On 27th, sodium was 157, potassium 3.6, and on 28th, 160 and 5.
There is hypernatremia and hypokalemia. And RFT little urea is elevated initially. So hypernatremic dehydration. Hypernatremic dehydration, hypernatremic, hypokalemic dehydration. What is the sodium level in usually in renal tubular acidosis, hypernatremia, or hyponatremia?
Hyponatremia.
Hyponatremia. Why? What may be the cause for hypernatremia? If it is renal tubular acidosis.
Secondary to dehydration.
Dehydration is there. When the fluid loss is more than solute loss, then there will be hypernatremic dehydration. So some way sodium has to go in, either in the feed, milk feed, maybe the formula contains more sodium. Which formula they are using? So is this sodium value after bicarbonate treatment? Any treatment given from the local hospital or
no, sir.
for the investigations?
No treatment was given.
Yes. Continue. Other investigations.
Blood gas on 25th, pH was 7.026, PCO2 of 24, bicarbonate of 6.3, and chloride of 127. And on 26th, the pH was 7.14, PCO2 21, bicarb of 9.7, and chloride was elevated 140. On 27th, pH 7.19, PCO2 28, with the bicarb of 11 and chloride of 137.
Okay. What is your comment? ABG.
Metabolic acidosis, hyperchloremic metabolic acidosis.
Metabolic acidosis. Okay. Any anion gap done? Anion gap? Anion gap metabolic acidosis or non-anion gap metabolic acidosis?
Anion gap was 13.
1-3.
1-3.
Okay. So that is normal anion gap, hyperchloremic metabolic acidosis. Yes.
Other investigations like pyruvate, lactate were normal, and ammonia was elevated. Chloride, serum chloride was 118, and blood ketone was 0.3. And these are the urine.
Is it a urea cycle defect? Urea cycle defect, ammonia elevated, organic acidemia, urea cycle defect?
Yes.
Urea cycle defect, there will not be any acidosis. Organic acidemia will produce anion gap metabolic acid. And ammonia will be very high. It is only marginal elevation, 120 only. That is not very high.
Urine sodium was 66, urine potassium 8, urine chloride 65, pH was 7.5, specific gravity 1, urine anion gap 9, calcium creatinine ratio was 0.59.
Your interpretation? Non-anion gap metabolic acidosis, hypernatremia, hypokalemia. Urine anion gap and urine pH. Which are the conditions you will get a anion gap is positive, isn't it? Urine sodium, potassium is 74. The urine chloride is 65. Anion gap is positive. Is it? Anion gap is positive. Urine anion gap. Is it? Hello? Divya, can you hear? Thomas, Divya seems to be out.
Sir, I will call him.
Yes, sir.
Urine anion gap is positive.
Yes.
Okay. So what is your diagnosis?
It could be tubular defects.
Which renal tubular defect? What are the different types of renal tubular defects?
Type 1 is distal artery. Type 2 is, hello sir.
Which renal tubular defect is possible? Hypokalemia.
Type 1. Type 1 and type 2 shows hypokalemia.
Type 1 is, there is a distal renal tubular acidosis. Type 1. Why?
Due to impaired acidification process.
Urine pH, yes. Acidification, urine pH is 7.5, above 5.5. In proximal, it is below 5.5. Urine pH is 7.5, high, alkaline. Okay, and hypokalemia. So it is a type 2. What about the calcium creatinine ratio?
It is normal for age.
This age, it is calcium creatinine ratio more than 0.8 or 0.7. So it's upper side of normal, but not very high. Okay. Can it be endocrine? Diabetes insipidus, hypernatremia is there. Urine specific gravity?
Specific gravity is low.
Low, 1001. Low specific gravity. Anyway, adrenal is not hypernatremia, not adrenal. Hypokalemia, hypernatremia is not adrenal. What is the serum osmolality? Not done. Okay.
Serum osmolality not done, sir.
Okay, sir, Purushottam, sir.
Finished discussion?
Yes, yes.
Okay. Very well discussed. You touched all the points. Both of you did very well. From the history part, when we are getting a bile-stained vomitus, it is simple. There is always surgical. When there is a non-bile-stained significant vomiting, possibilities of outlet to GI obsession, esophageal bar this thing. When such a presentation a little late, many of the congenital malformations are out. What remains is CHPS and a presentation of a malrotation. But the CHPS also, after this long duration, we need not consider. Malrotation is one of the, sometimes it can present with a large band without a bile stain. And from what you said, the possibility of a GERD situation is less likely. So in this case, by analysis, most of these surgical or the mechanical problems are out. So we need to consider other possibles, other extra GI reasons. One metabolic problem which can present a little late is fructose intolerance. So when you ask about the constitution of the artificial milk, always ask the dilution, of course, the frequency, the overall volume, and how you are preparing. Are you adding sugar? So that can present sometimes a little later with the vomiting missing. Other than that, as we said, many of the metabolic conditions we can consider, but the points are not totally for. Of course, the other thing comes commonest is a renal disorder. Rather than going to renal tubular acidosis, many other renal disorders, tubuloindecisional disorder, because the Liddle syndrome, Gitelman syndrome, other things are also need to be considered. Of course, the volume of urine is very important. Not only the times of passing, frequency, but the volume also. Overall volume is important because many of the conditions, there can be the clue. In a male child, the stream also. The stream and the volume also need to be asked in this history. And once you come to the family history, it becomes very simple. Many of the conditions are out. The other conditions you consider third and fourth are also very less common. The possibilities, of course, is first between the renal disorder and then the IEM. The other things are almost out by the time you get the family history also. So it is between the two conditions, out of which the renal disorders come high in the list. In the situation, one more point you need to consider, even when the renal tubular acidosis, there are underlying conditions sometimes, like the galactosemia sometimes can present, Lowy syndrome sometimes can present, but galactosemia you need to consider totally out. And few of the metabolic problems, there can be a combination like that, the renal tubular plus this thing. So in the general examination, very important points are the tone. In this case, tone is not affected. Usually, tone is important in many ways. One is, of course, hypokalemia in RTA producing hypotonia. Other conditions, again, Lowy syndrome-like situation, RTA is associated. So that way, and of course, the facial expression, extraocular movements and all are important. Then, dehydrated look is the other thing, the breathing. It is not the rate only, the depth of breathing is very important. Clinically, you didn't tell about the breathing pattern. Apart from this thing, the rate frequency, breathing pattern is important. In the once you come to the possibility, stream should be watched in this case. When the patient is passing male child, stream and the bladder things are important. So almost all the features are fitting for a tubular ulcer. So when you come to the ABG also, it is an anion gap calculation. You should do the calculation. So hyperchloremic acidosis, sometimes there can be mixed situation. So always stepwise, 6 steps you need to follow. Is it a metabolic acidosis, non-anion gap situation? Sometimes there can be a combination of anion gap and non-anion gap situations. So stepwise analysis of the ABG is needed. Okay. Then after this thing, the analysis of the electrolytes are important because there are few situations, Gitelman, it will be metabolic alkalosis. The BP is also important in the analysis. BP in this case is normal. So what is interesting in this case is sodium is persistently high and potassium is low. So that is a little bit odd about many of the situations. Sodium high, polyuria situation if you are establishing. Of course, one of the commonest is the diabetes insipidus situation, but the volume is normal. And in that situation, there is no reason for the potassium to be on the lower side. When you are getting a consistent high sodium with a low potassium, something wrong with the mineralocorticoid you need to consider. Mineralocorticoid problem. In RTA, there is a mineralocorticoid variety where the reverse is the situation. So you get a potassium on the higher side instead of the lower side. Here it is not so. So you need not consider that type for this thing, this RTA, RTA you need to consider. Then the mineralocorticoid problems sometimes maybe is there a combination like that you need to consider because it's very difficult to explain. And the last part, the stepwise analysis, you come to the RTA, it's not enough. Is it a distal or proximal? That part is important. By the other analysis, urine analysis, whether what is the pH? The RTA with the distal will never be, pH will not be cannot be brought down to lower. If it is 7, so that's a point need to be considered, and the urine anion gap, other things also need to be done for the distal bar proximal. Why it is so? Because it's eminently treatable entity, but on the follow-up, the possibilities and complications are different in distal and proximal. And by this time itself, ultrasound of the kidney should be done follow-up because the calculi formation is much more common in the type 1. So the management also has got a bearing on this thing. So for that, it should not be stopping with distal RTA, distal or proximal. And there again, next step is there any underlying reason for the RTA? And last part is the genetic studies for the further. Virendra, that's enough.
This child had a nephrocalcinosis also in the ultrasound. And it is not primary diabetes insipidus. If that is there, there will be contraction alkalosis. Here is acidosis. Tubular dysfunction, can there have a nephrogenic diabetes? This vasopressin activity in the renal tubules, is it defective? A combination of renal tubular acidosis with nephrogenic diabetes insipidus. Maybe that the sodium is higher. Is it possible?
Volume of the urine will be much more in that situation. And I don't consider that as a major.
Otherwise, there is more sodium intake in the diet or some, then there can have hypernatremia. Otherwise, that is an odd point in this.
An odd point, okay. And in the examination, Divya, and the neurological examination, most important things are the tone and the reflexes. Okay, in this case, tone seems to be normal and reflexes seem to be normal because many of these conditions you get a hypotonia and hyporeflex. And a very severe hypokalemia leading on to breathing on the lower side, apnea situation also can go. Even though commonest is the metabolic acidosis leading to deep breathing, when the hypokalemia very progresses, there can be a sluggishness of the breathing patterns.
That neck control, head control is a little delayed, maybe due to hypokalemia.
So very, very important practical points Virendran already mentioned. The feeding is so important because many of the metabolic problems, by the time you get this vomiting and all, the social, the other part, apart from the gross motor, other milestones will not be like this. Second thing, the feeding will not be that eager feeding will not be there. So those things are very important. The development milestones in the other fields is very important. The feeding, the hungry feeding is very important. And swallowing part is very important because one of the conditions I said, Dovey syndrome, even though it was just for completion's sake, the feeding will be very difficult in a case of the feeding problem will be there in a case of Dovey syndrome in the very younger age group. So many ways that active feeding is very important and the developmental milestones in the other fields are very important in this case in the clinical analysis.
Any rickets in this child? Any rickets? You said there is no chest rickety rosary is not there. Chest is normal. Any point against a beginning of rickets? Head is not large. Usually in rickets, head will be large. Forehead, so head will be large. Here the head is not that large. It is small.
The urinary analysis of the calcium, magnesium, all those elements are important. It's not the ratio only, so because the analysis of the tubulointerstitial disorders all should be coming. Don't only be biased by RTA only, because once in a while the other tubulointerstitial disorders also can present the very same manner. Their analysis is basically by three things. In the clinical examination, is there a BP? In the clinical examination, is it acidosis or alkalosis? And then comes the a type of the urinary excretion and electric abnormalities. So magnesium, calcium, all this in the serum estimation and the urinary excretions make the different diagnosis. Of course, the urinary volume, pH, specific gravity, and urinary analysis is so important in many of the conditions, tubulointerstitial, in many different ways. And of course, we didn't discuss about the other studies of differentiate between the distal and proximal, the acidification, what happens and all. So when you're coming to the renal disorders, tubular indecision, many things of theory which we should be practiced in the investigations.
Okay, Thomas.
Okay, sir, we can wind up. It's already 9.
Well discussed, Virendra, very good case, and all the areas you touched. Very good discussion. Both Divya, Thomas. Mohandas, നമുക്ക് wind up ചെയ്യാം.
wind up ചെയ്യാം സാറേ. വേറെ queries ഒന്നും ഇല്ലെങ്കിൽ.
Chat box almost all queries are answered.
Any comments or queries?
Sir, all queries are answered. Almost all queries are answered. I checked this chat box. Almost all queries are answered.
Okay, we'll wind up.
In that case, Virendra Kumar sir, thank you for that nice discussion, and Divya for nicely presenting the case. Thank you all those who have participated. Purushottam sir. Thank you.
Thank you.
Good night. Bye.
Good night.
Good night. Darling madam, good night.
Good night.